Welcome back to the RX class. I'm your host, Dr. Guang Chen. Thank you for your support so far. Today I have another very special guest, a good friend and colleague, Dr. Dev Nathani. He's a consultant neurologist working in Perth, Western Australia. A quick note before we start, please note that throughout the podcast episodes, the information presented is general in nature and used at your own risk. Complex concepts may be oversimplified for entertainment purposes. Symptoms and medical conditions, as well as the diagnosis and treatment of these conditions, may be mentioned. The information presented does not constitute the practice of medicine nor replace medical advice from a licensed medical professional. Do not rely on the information to make decisions about your or someone else's health. Please seek help from a certified health practitioner if you have concerns or symptoms. We do mention several conditions as well as medications in today's podcast. These are mentioned as examples rather than recommendations. Many of these examples relate to the Australian environment and may vary depending on where you live. We do not have any affiliations with these products or companies. Please consult your specialist for a personalized recommendation with regard to your own medical condition. Please enjoy my conversation with Dr. Dev Nathani. Today we've got a very special guest, Dr. Dev Nathani, who's a long-term friend. He's currently a consultant neurologist working in Perth, Australia. Welcome, Dev.
Thank you, Guang. Thank you for that very kind introduction.
Now, Dev, perhaps let's start with talking a bit about your background and how you got into neurology.
Yes. I've always had a very strong academic interest in the neurosciences, and that's really how I got involved with neurology to begin with. And throughout medical school, it was always my aim that I was going to become a neurologist. And once you start at the actual clinical practice, and you see the various kinds of uh, neurological disorders on a day-to-day basis, that really cemented my interest because there's so much disability. There's so much disability in the world of neurology, and for a long time, it's been a case of you can diagnose but not do much for treatment. But we've been so fortunate in the last few decades where that's rapidly changed with several diseases now that are either curative, if not much easier to manage, with so many treatment options that we didn't have at our disposal just 20, 30 years back. And that's rapidly gaining traction, even in say in the last few years. So it's a very exciting place to be.
Can you tell a bit about your training and how you got to become a neurologist? How
Yes.
long did it take you?
Yes. So after completing medical school, I did 1 year of internship and then 3 years of basic physician training. And then I took a bit of a gap to do a research degree, so a master's of philosophy. And that was really looking into the diagnostic utility of nerve biopsies in the modern era, because there don't really exist much in the way of clinical guidelines to help neurologists decide when is an appropriate time to be ordering a nerve biopsy. And I saw that gap, and so that's what my research was really based on. After doing that, I then completed the rest of my neurology training with a special interest in neurophysiology, which is what my fellowship was in. After completing all of the training, this was in the eastern states, I moved over to start my first job as a consultant neurologist in Perth, and I'm here still.
Can you tell us a bit about, I guess, what you do from day to day? Who is a neurologist and what kind of tasks do you do throughout the day and what kind of patients do you see?
Yes. So a neurologist is a specialist physician who deals with really any neurological disorder. And one way of, I guess, um, delineating the system is central nervous system and peripheral nervous system. So whereby the central nervous system deals with the brain and spinal cord, and then the peripheral nervous system really is whatever lies outside that. So your peripheral nerves, the neuromuscular junction, and the muscles themselves. So a disorder in really any of these areas falls under the purview of what a neurologist would be dealing with. But of course, there will be overlaps with other specialties. So, for example, several of the muscle disorders and, could be seen either by a neurologist or by a rheumatologist. Likewise, if it was a structural issue in perhaps the brain or cord, for example, then a neurosurgeon may get involved depending on what it is. So naturally, the overlap, but this is in general what we manage. And on a day to day basis, so I work in the public system, and so it's a very varied job. I'll be doing outpatient clinics, I'll be looking after inpatients with neurological disorders, in particular stroke, which is one of the most common disorders we treat. And then there's, of course, a lot of teaching involved as well, all the way through medical students, junior doctors, and even neurologists in training. And I happen to have a particular interest in neurophysiology. So I also run a weekly neurophysiology clinic where we test nerves and muscles using either electrical stimulation of the nerve or um, putting a needle into the muscles and recording their activity. I also run a Botox clinic, uh, and Botox can be used for various neurological disorders. I use it primarily for the management of chronic migraine, as well as for post stroke spasticity.
Dev, do you have a favorite part of the nervous system, or every part is your favorite?
Well, it'll be the peripheral nervous system. And look, I fell into this, really by chance. Throughout my training, I just happened to have a lot more to do with the peripheral nervous system throughout my research years. So, I know, like I was mentioning, my research interest in the peripheral nerves and into why one would do a biopsy. While I was looking into that, I also had I was fortunate to be able to receive some training into neuromuscular ultrasound, which again cemented that interest. And my fellowship in neurophysiology allowed me to really look at the peripheral nerve in multiple facets. So whether it's from a functional point of view using electrical testing, structural point of view using ultrasound, and of course I spoke about the biopsy part as well. So yeah, it's been a very big part of my training, and I really enjoy it.
Well, look, let's stay on the topic of the peripheral nervous system, I guess, since that's your
Hmm.
area of interest or of research. So perhaps you could take us through from beginning to end of a typical patient that may present, what kind of symptoms may they have, and why they would be referred to you, and how you would approach that kind of patient, what things you'd be wanting to know from, say, the history or the examination, and what tests you'll be ordering. And look, in very, very broad terms, for say an example diagnosis, what are the treatment options available for that patient today versus what it was available, say, 5, 10 years ago versus what it might be available in another 5 or 10 years.
Okay. Well, I mean, of course, this is despite being a very particular part of the nervous system, there remain, of course, a very, very uh, large number of potential causes of diseases that involve this area. Now, um, perhaps I could start with common things first. The most common peripheral nerve disorders that come to the attention of a neurologist. So, if I were to use my neurophysiology clinic as an example, one of the most common things I get referred is patients who have numbness or weakness in their hands or feet, and they want to have testing done uh, to see whether there's perhaps example of a carpal tunnel syndrome or ulnar neuropathy or a peroneal neuropathy or just a generalized peripheral neuropathy. So these would be some of the most common
I'll
reasons.
just
I
stop you
mean,
there briefly, Dev, just for the people at home who might not be doctors.
yes,
Maybe if you could just clarify what you mean by a neuropathy, and
yes,
these words with ulnar and radial and the carpal
of
tunnel.
course, yes.
We'll
So
keep it as simple as we can for everyone to enjoy, rather than us medical professionals.
yes, no, of course. Thanks for reminding. So, Really, when I use these terms, I'm referring to the names of various nerves. And when there's a damage to a nerve, we use the term neuropathy. And so when I say that the term median neuropathy, ulnar neuropathy, or peroneal neuropathy, what I mean is nerve damage of these nerves, right? So it could be nerve damage to the peroneal nerve, which we then refer to as a peroneal neuropathy, nerve damage of the ulnar nerve, which would be an ulnar neuropathy. So and these neuropathies, like I was just alluding to earlier, will present with either numbness and or weakness, and sometimes superimposed pain as well. And that's really how they come to our attention. Now, in terms of the workup, and as with most of medicine, it starts off with history, a very very good history, and we be asking questions like, when did it start, what is the nature of the symptoms, is it only sensory, is there weakness involved, is there pain involved, which part of the body is the symptom involving, is it symmetric, is it asymmetric, how has it progressed over time, and are there, of course, any other associated symptoms. And then this would be looked at in the context of the patient's background medical history to give us some clues as to what risk factors the patient may have. Such an example just being perhaps diabetes, because we know that patients with diabetes are at a much greater risk of developing what we term as peripheral neuropathy, which is damage to the most peripheral nerves in the body. So typically, patients who present with numbness or tingling in their feet, which gradually progresses over time to much more proximal regions of the legs and eventually even the hands. So something like that, right? Now, then we come go on to examination, and with examination, really with you know, we're trying to look for many of the same things. So in terms of, is there symmetry in terms of the involvement, is it a single nerve involved, is it much more than that, is it mostly weakness that we can find on examination, or is it mostly a lack of sensory perception, or both perhaps. So and then you move on to ancillary testing such as imaging. So perhaps you could use MRI or ultrasound or CT scans, depending on the clinical suspicion, right? So, for example, if I was thinking that the reason for this patient's uh, sensory symptoms and or weakness was that the ulnar nerve was trapped or compressed at perhaps say the elbow, I would request an ultrasound to look at the elbow and what's happening to the ulnar nerve as it passes through the elbow. So that's just an example. And then neurophysiology wise, which is what I do, so the nerve conduction studies I was talking about, that gives us an idea of the function of the nerves. So, using the same example of an ulnar neuropathy at the elbow, so when I do the testing, I'll be looking for evidence of slowing down of the speed at which the nerve is conducting is the electricity as it passes through the elbow, which will then help me to confirm that diagnosis. So that's just one example. And then in terms of uh, treatments, of course, uh, that just depends on what the issue is. So in terms of the more common sort of diagnoses, say carpal tunnel syndrome, we can have something as simple as conservative management, which is just using splints, for example, to keep the hand, that's right, the hand in a position that doesn't allow it to move too much when sleeping. And if it is really severe, then even surgery might be required. And likewise for ulnar neuropathy, there are times when a surgery is required to fix the problem. But if it's really mild, it'll just be advised to avoid putting too much pressure on the elbow. Now, so these are obviously the most simple ones. it can become a lot more complicated. So we, on the other end of the spectrum, would be, I guess, one of the my special interests, the motor neuron disease, which is a clinic I run once a week. And over here, you've got a very complex neuromuscular disorder, whereby we have patients with usually very rapidly progressing weakness of various muscles in the body. So it can be the arm muscles, the leg muscles, the muscles that involve speech, swallowing, breathing, that get sequentially involved in usually rapid succession over a period of time, and leading to the patient passing away on average 3 to 5 years after the symptoms first come on. Now, uh, this is obviously a very devastating diagnosis for the patients, and I mean, once we get over the diagnostic part of things, as far as treatment is concerned, unfortunately, as of now, we have very limited medical options, but we do know that there's a lot of clinical trials happening nowadays, and there's quite a few studies that are in phase 2 and phase 3. So it is hoped really that over the coming 10 to 20 years, that we will have much better treatment options compared to what we currently have.
I think my maternal grandfather, I think, had motor neuron disease, and he passed away when I was fairly young. I think was 3 or 4 years of age, and I remember vaguely my memory that he essentially wasted away. He
Hmm.
was to me at the time, he was a giant of a man, and over a course of a few years, he was literally bedbound, and I think he then started having difficulty feeding himself, and then ultimately, I think he had issues with breathing. And I think ultimately ended when his heart just couldn't take it anymore. And I think
Mhm.
again, to my mum's recollection, I think it all happened over 2 to 3 years.
Yes, and that, unfortunately, over the last several decades, the life expectancy hasn't changed that much, which is a testament to how modest our current treatments are in terms of their benefit.
And again, so for the people at home, so with motor neuron disease, which part of the peripheral nervous system is it affecting? Is it affecting the muscle, the junction between the nerve and the muscle, or is it affecting the nerve? So I guess just for people to know um, what is actually happening.
Yes. So, motor neuron disease is actually an umbrella term. So within motor neuron disease, you've actually got a few different subtypes. Now, the most common subtype is called amyotrophic lateral sclerosis, which is what you were referring to as Lou Gehrig's disease. So, and which is the most common subtype. And in that subtype, you've got involvement of both the upper motor neurons and the lower motor neurons. So, to, I guess, use layman's language, when we want to use a specific muscle, and what happens is our brain needs to send a signal from the brain all the way down to the spinal cord and onwards to the muscle. Now, the initial neuron that starts in the brain and travels all the way down to the spinal cord, and that is what we refer to as the upper motor neuron. From there, it communicates with the lower motor neuron, which is what then leaves the spinal cord and travels all the way to the muscle. And then that lower motor neuron will then communicate with the muscle. So in ALS, or amyotrophic lateral sclerosis, you've got involvement of both the upper and the lower motor neurons. Both of them are degenerating. In There are some other variants. So, for example, there's a variant called PMA, which is progressive muscular atrophy. So, in that, you've got only the lower motor neuron that is involved. And then you've got another variant, which is PLS, which is primary lateral sclerosis. And in that, you've got only the upper motor neuron. that is involved. So these are the three main ones, and there are other ways of classifying motor neuron disease. We could use site of onset, for example. So is it bulbar onset, whereby it starts off with involvement of the speech and swallowing muscles, or is it limb onset, whereby it starts off with the involvement of an arm or leg? And very rarely you can also have respiratory onset, which is where the breathing muscles are the first ones to go.
And so at the moment, I guess with motor neuron disease, the treatment is largely supportive care. Would you say that's to support the patient and to provide, I guess, quality and quantity of life?
Yes, correct. So in term, so yes, if we separate it out into medical treatment and supportive treatment, in terms of medical treatment, there is a single drug called Riluzole, and that's been around for decades now, and it definitely works. There's no doubt that it does reduce the speed at which the disease progresses, if you look at the clinical trial data. But the benefit is in the order of about 3 months, if you were to look at the original trial, in terms of the increase in life expectancy of the patients who were given the drug versus the placebo arm of the trial. There have been some prospective studies done subsequently, which estimate the benefit to be perhaps a bit more in the uh, range of 6 to 9 months. But really, if you focus only on the randomized control trial data that we have, then the number we quote is about 3 months increase in life expectancy on average. Now, in terms of other drugs, there is a drug called edaravone, which is an infusion form. Now, the issue with that is that, like I said, it's an infusion form, and it has to be given several times a month, and you need to be in hospital for all of those days. So, for someone who is already having a life limiting disease, to then spend that much more time having multiple infusions several times a month. There are one or two drugs in other countries which can do get given, but again, nothing that has very significant benefit, and particularly not more than riluzole for sure. And that's where we have clinical trials that come into play. So we do have lots and lots of trials occurring throughout the country. We just concluded one recently at the center I work in, which is the Perrin Institute in Western Australia. And we have another trial that will be starting shortly in the next few months. So, those are the options really that we can offer to our patients as far as medical treatment is concerned. Now, as far as supportive care, so that really refers to involving our colleagues from allied health. So we've got the physiotherapists, speech pathologists, the dietitians, the occupational therapists, the nursing staff, and in terms of other medical teams, of course, we've got the respiratory and sleep medicine specialists who really monitor for the development of respiratory failure, and discuss with the patient in relation to commencing on, well, what we call non-invasive ventilation, but which really is referred to a mask that helps to push air in to overcome the weakness of the breathing muscles. And we also have, we work very closely with our colleagues from gastroenterology in relation to PEC tubes, because as the swallowing muscles weaken over time, and this is something that they often require to supplement their ability to have enough oral intake.
Yes, I guess the disease is very debilitating and distressing not only for the patients but perhaps for the carers as well.
Yes, and that's why we also work very closely with patient support organizations. So, for example, in Western Australia, we have this organization called the Motor Neuron Disease Association of WA, and they have similar organizations in all the other states in Australia as well. So they are very, very useful, not only because it's a patient advocacy and support group, but they often provide support like respiratory physiotherapists, occupational therapists, people that can help to navigate the NDI system or the age care package system for patients who are trying to, or to deal with uh, quite a devastating illness to then you know to help guide them through what can often be a very convoluted system in trying to access support through NDS or the age care packages.
Thank you for a great discussion on motor neuron disease. It's something very personal to my heart. Look, I mean, we might finish up our current podcast in terms of where do you see the challenges with neurology at this stage, and do you see any solutions in the next 5-10 years? Do you think AI is going to make a big impact on neurology?
Well, look, in terms of the challenges, I think the challenge will still remain similar to the kind of challenges we have faced in even 20, 30 years ago. In that, um, while we are making great strides in terms of therapeutics, they remain very suboptimal. I mean, of course, motor neuron disease is a classic example of this, but the same can be said for many other diseases, but particularly perhaps things that I will give examples of some of the movement disorders such as progressive supranuclear palsy, some of the neurodegenerative disorders where we don't have very good treatment options. Even something like Alzheimer's, it's only in recent times that we started to get some sort of therapeutics coming into play, but the evidence for those and the efficacy is still quite wanting. As far as AI is concerned, I think it is exciting, and this is coming into play mostly in the imaging domain. So we do know there's a lot of study done into looking at how AI can be used to interpret, say, CT scans for patients who get scans, and it's uh, eh, there may be a very long wait time before a radiologist can have a look at the scan. So in those kind of circumstances, having AI to give a very quick report pending formal radiologist review can be quite helpful. And of course, there's also the case of trying to improve diagnostic sensitivity. This is particularly the case in inflammatory diseases. So we know that there's a lot of work being done in the MS space, um, trying to see if we can use AI to calculate things like brain atrophy over time and various other parameters that can help, to guide clinical decision making a lot more. But this is yet to enter clinical practice, but it is, definitely be looked into.
Well, thank you so much, Dev, for your time.
Yeah, no problem at all. Thank you.
Hope we can catch up another time to talk about something else.
Yes.
There's
Well,
so much to talk about in the nervous system. I'm really excited.